run this well, but do please bear with me if there's any glitches. You're all very welcome to this second meeting of the new Old Age Liaison Network. It's our great pleasure to have you with us today. We've got a great lineup for you for the next hour. We are going to be playing a talk by Alasdair MacLullich, who many of you may have heard of, and then we're going to have a really good panel discussion about the role of old age liaison and other aspects of managing delirium in the emergency department. And we've got a wonderful group of panelists with us to help with that discussion, who are all, I can see them all still. I'm just going to ask you guys to turn your cameras off and rejoin us later. Thank you. Lovely, thanks very much. Okay, so we're going to run through a little bit of housekeeping. We're going to do a few polls. We're going to give you an update on the recent activities of the Old Age Liaison Network. We'll move into Alasdair's talk, and then we will go into our panel discussion, and then we'll have some closing polls and comments, and hopefully you can do a feedback form for us as well. A bit of housekeeping, as I mentioned, this is a webinar format, so a bit different to last time. We can't see you. Please use the chat box to say hi and make comments, and use the Q&A box for any questions for the speaker or panelists. We'll be using polls during this webinar, so we'll give that a go in a minute to check that's all working okay. And I'm going to ask the panelists to keep their mic and video off unless they are active. This meeting is being recorded, and we'll make the recording available after the event, so please don't worry if you need to leave early, or for people that are joining late, they'll be able to catch up. And do please fill in the feedback form after the event. So we just want to get to know you a little bit, make sure that the chat box is working okay. Please could you let us know in the chat box, where are you joining us from and what is your professional role? So over to you guys. I can see Belinda is excited to be here. Belinda's our wonderful service manager. Hi, Belinda. And Kamala works for our team as well. Wonderful. Lovely, thank you. Lots of liaison psychiatrists here, all over the UK. Liaison nurses, fantastic. Nurse lecturer in London. Hello, hello. Physiotherapists, hello. Wonderful. Welcome to all of you. Thank you so much. Fantastic. So please feel free to use the chat throughout the webinar, chat to each other, share ideas, share thoughts. Wonderful. Okay. So now we know how to use the chat box. We're just going to use the first poll and check that that is working. So the first poll is, do you routinely practice liaison psychiatry for older people? So please answer. You should have had the poll pop up. Lovely. Keep going. Just keep it open for a bit longer. Okay. Few more to respond. We've got 83 out of 105. Just wait for a few more. Okay, so we'll end that one. I'll share the results with you. So you should be able to see our results now. Panelists, can you just let me know that you can see the results? One of you.
I can.
Yes, Josie. Yeah.
Lovely, fabulous, all working. Okay, so 62% of you routinely practice liaison psychiatry for older people, and 38% do not. I think that's actually quite surprising. I thought it would be more yeses there, but that's wonderful that we are attracting people who don't routinely work in the field. That's great. I'm going to just launch the second poll now. Okay, so second question, what delirium tools do you use in your service at the moment? I appreciate some of you may not be able to answer this if you're not working in a liaison service, but also interested to hear if any service that you work in, even if it's not liaison, what delirium tools do you use? And if you don't use the 480, the squid or the cam, let us know in the chat box. Okay, just a few more seconds and I'll end this poll. Okay, so probably unsurprisingly, the vast majority of you are using the 480, 82%. Some using the single question delirium, 7%, and then quite a few more using the confusion assessment method. And some of you are using others. Just have a quick look in the chat box. We've got AMT, non-routinely, no formal tool, used biopsychosocial assessment. Fabulous. Okay, thank you for that. All right, so I'm going to hand over to Liz now, who's going to give you a bit of an update on the network's activities.
Hi everyone, so my name is Liz Sampson. I'm a clinical professor at UCL and also a consultant liaison psychiatrist and clinical lead at Barts and Royal London. So just an update really for those who haven't come across us before. It was a sort of informal network and group that started about 9 months ago, and we now have 350 people signed up to our mailing list, all who have an interest in liaison psychiatry for older people. It remains an informal network for now, so I've been asked to stress we're not an official Royal College of Psychiatrists network yet. We had our first seminar in November where we had a really useful and interesting update on the new liberty protection safeguards. That recording is available. We had 100 people attend then, and we'll post links so that you can look at that recording if you would like to. We also had a session as part of the older age faculty meeting last month, and we had a fantastic update on Parkinson's disease from Dr Alasdair MacLullich from Cambridge. We're also having a future seminar which is planned at the liaison psychiatry faculty on eating disorders in older people. And you can see that we choose really clinical topics that are of day-to-day interest for older adult psychiatrists or people who work in liaison psychiatry generally, whether in hospitals or in the community. Please let us know if there's any topics that you'd like us to cover, and also feel free to suggest speakers. You can put those in the chat as well. And after this, you'll receive a transcript with the chat and some of the themes and all of the links in a document. So thanks again for joining us, and I'm going to hand back to Josie to introduce our speaker.
Lovely, thank you. Okay, so it gives me great pleasure to introduce this talk given to us pre-recorded. Unfortunately, he can't join us till a bit later, from Professor Alasdair MacLullich, who you probably all heard of. He's Professor of Geriatric Medicine at Edinburgh University. He is the author of the 480, which, as we know from our earlier poll, most of us are using as our screening tool for delirium. And he is founder of multiple networks in delirium and a co-author of the SIGN delirium guideline, which is very widely used in delirium care. So give me a second and I will just start sharing his talk. Can I check that you can all see my screen? That's when the panelists can tell me.
Yeah, I can see your screen, Josie. I'm not hearing any audio, Josie.
Okay, let me just sort that out.
Good afternoon. I'd like to thank Dr. Jenkinson and the
I'm
other
hearing that now.
for inviting me to give this brief talk on delirium in the emergency department. My aim is to focus on clinically pragmatic aspects rather than go through lots of evidence, but I'm very happy to be contacted if you would be interested in seeing any references. So just a quick overview. As we know, delirium is very common in the emergency department, with around 1 in 10 patients having it, with higher proportions in older patients. And in the UK, the ED kind of stands out as a place where delirium detection remains particularly poor, with recent audits showing that more than 75% of delirium is missed in the ED. And this is a problem because people with undiagnosed delirium are often discharged, and some evidence suggests that these patients do particularly badly, with high readmission rates and even much higher mortality rates. So moving now to covering delirium care, I'm going to be talking about these 3 processes that are involved in delirium management, and all of them apply in the ED. Moving now to detection, the first question to ask is, should we try to detect delirium in the ED? And the reason for asking this is because it is an area where time is at a premium, where differences of 30 seconds to a minute per patient can really make a difference in terms of what is prioritized. And also the legitimate question of, if it's diagnosed, are there actions that can be taken at that time that make a difference to the patient? I would make a very strong case for saying, yes, we should detect delirium in the ED. And I think the main reason, and the only reason you really need, is the amount of distress that patients with delirium suffer, particularly in such a hostile environment. And also we know that interventions can help to reduce this distress. There are, of course, many other different reasons to detect delirium in the ED, but I think this is really the only one you need to make the argument very strongly. I wrote a blog a couple of years ago on all the different reasons I could think of to detect delirium. I'm not going to go through them just now, but you can see that a lot of these really do apply to the ED as well, including being a presenting feature of life-threatening illness, for triggering a delirium pathway, for communicating the diagnosis to patients and carers, and so on. So for these reasons, the Royal College of Emergency Medicine recommends that delirium should be detected in the ED, and also that cognitive impairment should be detected as well. And the tool they recommend for use for these purposes is the 4AT. What's also, I think, important in these recommendations is number 4 there in the list. There must be clear documentation of identified cognitive impairment and/or delirium to aid transfer of patient care. And this applies both to patients who are being admitted and to patients who are being discharged home or to the care home that they've come from. Now I'd like to move on to detection itself. So one of the important findings from many studies is not only that in general delirium is not detected well in the ED, that clinical gestalt as a kind of method for detecting delirium, which many clinicians rely on, especially in the ED apparently, doesn't work reliably, with overconfidence about the diagnosis being a common manifestation and consequently much delirium not being detected. And in particular, it's the hypoactive delirium that is often not detected. I think this may be because there is a big focus in the ED around agitation and acute behavioural disturbance, which I'll come to later. This is, of course, entirely understandable, but it does mean that the quieter patients who are not arousing attention from the staff are often not considered to be delirious. In terms of the methods, There are many delirium tools, about 60 in fact, but only a few have been validated. Some people have recommended that a two-stage process is used to save time, and I'll be talking about one of those in just a couple of slides. But in terms of if you distill down to the tools that have been validated in the ED and that seem to be practical for the ED, the 4AT, the delirium triage screen, and the brief cam are the ones that come out of any literature research. So the 4AT was developed around 10 years ago, and it is a tool that incorporates some cognitive testing. So it does fulfill the criteria from the Royal College of Emergency Medicine to incorporate a little bit of cognitive testing. But its main purpose when it was designed was for simplicity and speed. And one thing that was different about the 4AT compared to the tools existing at the time is the initial focus on sleepiness or altered arousal. So that could also include agitation as being the first thing that's assessed, then a little bit of cognitive testing, then an assessment of acute change or fluctuating course. And the 4AT is now the tool with the most validation data in general of any delirium tool, with some validation in the ED as well. The delirium triage screen was published at around the same time as the 4AT, and this is the first of two suggested stages for delirium screening. And this requires that the patient is initially screened for altered level of consciousness, so similar idea to the first item in the 4AT, and then a simple attention test asking the patient to spell lunch backwards. And then if this screens out, then no further testing is required. If it's positive, then a further test is recommended. And the test that is paired with the delirium triage screen in the initial study is the brief confusion assessment method. So this is the brief CAM, and this is kind of the confusion assessment method, one of the older delirium scales, operationalized a bit more with some built-in cognitive tests and a test of a disorganized thinking. And it does have reasonably good psychometric data, and it's quite a popular test, mainly in the US. I haven't seen many studies around its implementation, but it does appear to be a test that can be implemented reasonably well in practice. With respect to comparing it to the 4AT, the only, I suppose, drawback is maybe that there is no more formal and interpretable cognitive testing items involved, including orientation. However, I think the 4AT and the DTS/brief CAM combinations are both workable solutions. One thing that I like to emphasize, and I don't need to tell the particular audience today about this, but just in terms of passing this on to colleagues, is that these initial quick screening tests aren't all that good at picking up the richness of the delirium syndrome. And this richness is very important because of the implications for treatment. So I think we always have to follow a delirium diagnosis with some kind of record of what is this individual patient's delirium like, including the potential for the presence of delusions and hallucinations. And I was struck by this in a book chapter that I read many years ago, that we've kind of forgotten about mood in delirium. Certainly in the general medical and geriatric settings, it's not something that is necessarily focused on all that much. And in fact, studies show that probably 60 to 80% of patients with delirium have important mood changes, which are usually not positive. People are usually low in mood or very anxious if they have mood changes in delirium. Another thing that's, I think, important to bring out in any teaching of ED staff is the fact that not all change in behavior can be attributed to delirium. Sometimes it is somebody with dementia who they may have some behavioral disturbance pre-admission that just continues on, or maybe the admission to the ED and all the stress associated with that exacerbates this. And this isn't delirium necessarily, it's just the dementia combining with the hostile environment of the ED. Anxiety can be very severe and can look like agitation. Hearing impairment, I've seen that many times, just people looking like they're not understanding and they're disorientated, and using some kind of amplifier can really make a difference to that kind of situation, or providing the hearing aids if they're available. Severe pain as well can look like agitation and also urinary retention. So it's important to consider these at the outset before confirming that it is a delirium. Now I'd like to move on to delirium treatment. So this scheme, the delirium 8 scheme, is essentially based on the SIGN guidelines, the Scottish Intercollegiate Guidelines Network guidelines on delirium, published in 2019. And it takes the approach that there are many different domains that you need to consider when treating delirium. When treating delirium in the ED, not all of these are immediately applicable, and some of them are just aspects of care that need to be planned. But I'm going to go through some of them just now. So obviously the first step is to look for life-threatening causes. I think sometimes agitation can be distracting, and that things like low blood glucose, low blood oxygen, drug intoxication can be missed, and the patient might just be labelled as somebody who's a bit agitated or hyperactive delirium, especially if they're old, without necessarily a careful search for these causes, and they often can be found. Once that initial screen's done, then the standard approach is obviously to look for triggers, which can be very diverse, of course, and at the same time to do all you can to optimize conditions for brain recovery, including improving the patient's physiology as much as possible. One example of this that I've introduced in hip fracture care in Scotland is to give every hip fracture patient who comes in through the door intravenous fluids at the point of diagnosis of hip fracture. Obviously, most patients at that stage don't have delirium, but this is one way of just making sure that if they do have delirium, that they're not going to become dehydrated at the time. I'd like to focus a little bit on distress. The first thing to say is that it's very important to detect distress and to document it as such. And I've done a couple of audits recently in inpatients showing that there's very little documentation of any attempt to document whether a patient has distress and to do anything specific about it, perhaps other than maybe a mention of the word agitation. So it needs to be looked for proactively in all cases of delirium, because it's really common in delirium. And if it is detected, then the common triggers, as listed on the left, are very important to look for in a very proactive way. Where I work in hip fracture care, the first two on the list on the left are extremely common, retention and pain. And, I sometimes make the point that retention is not treated very well by haloperidol. And, haloperidol is not a good analgesic, but you do see haloperidol used to treat, open quotes, agitation, close quotes, which has been a result of urinary retention or pain. So this systematic search is really important so that we can effectively address the remediable causes. Once that's done, I think the treatment of distress itself involves more than just looking at the causes. It involves communicating with the patient, involving the family where possible. If it's very severe and it's warranted, one-to-one nursing, and drugs really only if necessary. And I'll come to that in a second. I want to talk a little bit about pain first, though. So in my day-to-day work in hip fracture care, this is obviously a very important consideration. And looking into the literature, it's fascinating to discover that although, of course, we recognize that self-report is important, that these kinds of scales, the FACES pain rating scale I have, pain thermometers, they're not all that good in patients with dementia. I probably don't need to, again, to emphasize this too much to this particular audience, but it's very surprising to me that these are often recommended as tools for pain assessment when they don't actually work all that well. And so maybe it means that lots of patients are in pain because they've not given a clear answer from these kinds of verbal report methods of detection of pain. So I think that we need to use other methods, looking at facial expression, looking at patients' posture, listening to them, asking nurses who are looking after them, asking family. There are scales like the Pain AD scale, which are quite effective, but in my experience, it's difficult to get those implemented. So simply being very careful about looking at somebody's face and looking for potential sites of pain is a very important part of any assessment of distress within delirium. I also would like to stress something that I think has been missed in the delirium field, which is that speaking therapeutically to people with delirium seems to be very effective. It's not something that's trial-based, but in a way it's kind of common sense that people have had delirium often report the difference between being spoken to in a certain way, which has been helpful to them, and compared to those who have maybe ignored them or spoken over them or started doing procedures without explaining what's going on. So I think always explaining to somebody what's going on and telling them what is about to happen is really a very valuable part of delirium care. And I think that's particularly important in the confusing environment of the ED. So I'm sure it's clear to this audience that there is no evidence for using drugs as a treatment for delirium. There is only some expert consensus that when there's particular circumstances within delirium, such as intractable distress or safety problems, that there may be a role for drugs. And I myself use drugs infrequently, probably once a month, and I see 5 or more cases of delirium every week. So in the ED where maybe there is a safety concern which needs to be addressed quickly, once the non-pharmacological routes have been tried and they failed, there could be a role for small doses of these drugs, but really they should be used infrequently in patients with delirium, in my opinion.
With ongoing care, once the medical causes have been identified, hopefully, and distress has been assessed for, and so on, I think the wider team is very important in planning future care, including occupational therapy, which can help in the decision to discharge a patient or not. Specialist nurses, I think, are very, very valuable in managing the overall plan for a patient with delirium, and involvement of psychiatry, although it's something that obviously we'd prefer to have much more of, if the resources allow, can be very helpful, especially in complex cases where there's dementia as well. And in terms of planning discharge from the ED, in every case, there's a cost-benefit analysis to be done. It's not necessarily safe to keep somebody in hospital if a safe home environment may provide a better environment, especially when there's a simple cause of delirium identified and that the management seems straightforward. Many places now have hospital home facilities that can provide perfectly safe ongoing care, and there is a small number of trials that show that delirium care home is perfectly safe and possible for some patients. So just a few words about delirium prevention. So unfortunately, there isn't all that much evidence from trials that have looked specifically at ED populations. However, most people extrapolate to the reasonably good evidence base for delirium prevention in inpatient settings. And I'm not going to list all of these just now, but this is drawn essentially from the SIGN guidelines of 2019. And all of those kinds of interventions appear to reduce the risk of delirium in people who are high risk. And I suppose you could summarize it by saying that good overall holistic routine care is really helpful in reducing the risk of delirium. Taking care of the brain and the body, don't let someone become dehydrated or constipated, avoid giving them drugs that are deliriogenic, and so on. Now just a few words on this recent draft guidance on acute behavioural disturbance. So This came out quite recently and aroused some concern on Twitter and in various networks of people who saw this. And some of the concerns that geriatricians have raised are listed here. It's a bit concerning that in the main summary of recommendations, which of course many people will default to as their main way of getting an idea of what's being recommended, there's no mention of delirium at all. And yet this is a strange way of approaching this issue because, of course, in older patients where there is acute behavioural disturbance, this will often be in the context of delirium rather than some of the many other causes of acute behavioural disturbance that are much more common in younger people. And if you couple this with the fact that a minority of delirium is ever diagnosed in the ED, this I think means that there could be a risk of the default being that acute behavioural disturbance is the label rather than delirium. And that means, of course, the disadvantage of that is that the systematic approach to delirium management that I've outlined before will not be applied. And then because this guidance really quickly moves to the use of drugs, there'll just be the treatment that's used as soon as there's an older person with acute behavioural disturbance. I think that's a very high risk, from the guidelines as they are currently written. Another real concern from this is the doses that are being recommended. Even if they say in older people or failure people that doses should be reduced, they're really quite high doses. They're recommending about 5 or 10 times the size of dose that we would usually use in geriatrics, and even then we're not using drugs very often. So I think hopefully the consultation will lead to revision of some of these and a much greater emphasis on the necessity of a delirium diagnosis and proper systematic approach to treating triggers of acute behavioural disturbance, even though of course it can be part of delirium. One quick point about this is the RCM draft guidelines mention ketamine and droperidol, and this systematic review just came out a few weeks ago really recommends using ketamine droperidol, but if you read the article and look at the studies that they included, 11 studies, all of them had an age range of 30 to 50. Not a single study had old people included. So I think there's great danger of extrapolating this otherwise probably quite reasonable recommendations for younger age groups. And just to conclude, a few words on implementation. This is a very interesting paper that's just been published in Age and Aging, and it really neatly brings to the surface findings that have been present in various forms, various studies over the years, including the lack of prioritization of delirium, the mismatch of perceived knowledge and actual knowledge, and also the role of hospital culture in driving good practice. So I think if we look back at the history of delirium care and its implementation in the UK and elsewhere, a few hard lessons have been learned. I think the main lesson I've taken from it is that multiple things need to be done to improve delirium care. These include, of course, bedside skills, but there's much more to it than that. I think attitudes and culture are critical, as that last paper showed. Leadership's very important, standards, and ongoing audits, which, to be honest, so far have really shown very poor performance of EDs in detecting and managing delirium effectively. So I think to try and improve this, multiple aspects need to be addressed. So I'd just like to conclude with this slide, giving some encouragement that introducing the NICE guidelines in England in 2010, along with lots of education across the whole country, has made a big difference, I think, to delirium coding, and this is across the whole population. It isn't a study, it's all hospital data across Scotland and England showing big increases. So it works to do these kinds of efforts of education, audit, guidelines and so on. So we just need to keep going. Thanks very much indeed.
Fantastic. Hopefully that worked well and you could hear the presentation well enough. I had a message from my consultant colleague saying you could see half a screen as a talk and half as my face. So I'm hoping that wasn't the same for all of you. But anyway, I'm going to ask all our panelists to put their mics and videos on. I can see that Professor MacLullich has joined us now, which is fantastic. Hi, everybody. Hello.
Hi.
Hi, everyone.
Hi,
So,
everyone.
hello. I have a few pre-prepared questions to get us going with a bit of a discussion about this, but do please feel free, guys, to put questions in the Q&A. And firstly, thank you very much, Professor MacLullich, for pre-recording that talk. I know you've been here, there and everywhere today, and we really appreciate you making the time to make it work. I'm going to do a quick round of introductions, if that's okay. I'll ask you all to introduce yourself. I did introduce you already, Professor MacLullich, but perhaps you'd like to introduce yourself again quickly.
Yeah, well, thanks very much. So I'm a geriatrician working in Edinburgh. I'm also an academic, and I've got an interest in delirium detection, biomarker stuff, and I'm 50% clinically active. So very much enjoy my clinical work and learn something new every day.
Thanks very much. And Dr. Morris, could you introduce yourself, please?
Yeah, hello everyone. I'm Dr. Rachael Morris. I'm an associate specialist in geriatric emergency medicine and acute frailty. So I term myself as a bit of a hybrid doctor between geriatrics and emergency medicine. And I've got the pleasure of being the clinical lead for the geriatric emergency medicine service at Western General Hospital in Weston-super-Mare, which is a front door multidisciplinary team, and will see any frail patient that comes into the hospital, regardless of presentation, however unwell they are, and that negates the need to see our ED colleagues. And I'm also the chair for the special interest group at the Royal College of Emergency Medicine, looking at best practice for older patients in the emergency department.
Lovely. Thanks so much, Rachel. Chris, do you want to introduce yourself?
Hi, good afternoon. Thanks, Josie, for organizing. And thanks, Alasdair. As always, amazing talk. I'm Mani Krishnan. I'm an old age psychiatrist. I'm the chair of the old age faculty. I work with Josie closely, and me and Josie have the passion of delirium. And it's great to see multi-professional engagement of over 130 people live and 250 people registered. So it's a great validation. Thank you.
Thanks, Krish. And Dr. Overshott, please could you introduce yourself?
Hi, I'm Ross. I'm a liaison psychiatrist in Greater Manchester and Salford. I'm also the co-lead for liaison across Greater Manchester as well.
Lovely, thank you. And Dr. De Weymarn, could you introduce yourself, please?
Hi, I'm Dr. Tanya De Weymarn. I'm an emergency medicine consultant who's subspecialised in paediatric emergency medicine and then in frailty. So I work a quarter of my time in frailty now, and I work in Gloucestershire.
Thank you. And Annabel, could you introduce yourself, please?
Hi, I'm Annabel Price. I'm the chair of the Faculty of Liaison Psychiatry at the Royal College of Psychiatrists. I work as a liaison psychiatrist with an older people's team based at Addenbrooke's Hospital in Cambridge.
Lovely. And Liz, you introduced yourself already, I think, and I'm not sure if I did introduce myself properly. I'm Josie. I'm vice chair of the old age faculty at the Royal College of Psychiatrists. And as Krish mentioned, we work closely together, and I think we all here have a very keen interest and passion for delirium care. So just a reminder to please use the Q&A function for any questions you want to ask the panelists. It's a bit tricky to try to go back and forth between the Q&A and the chat. I'm going to start us off by asking you, Alasdair, hope you don't mind me calling you that, and others to chip in. Should everyone over 65 presenting to ED be screened for delirium?
So yeah, I would say ideally yes, but I think in the real world, some selection of patients is reasonable, and I'm interested in Tanya's viewpoint on this. People have developed various risk, stratifications, like to see who should be screened. 2 minutes is, not trivial in the ED, for somebody who's doing work, and even a very short screen. I think we haven't yet worked out how to do delirium screening effectively in the ED. There are two-stage tools like the BCAM, you know, the delirium triage screen. Do you know what that is? So that's basically, is the patient drowsy, and can they spell lunch backwards? And if either of these, you know, are triggered, then they move to a more definitive screen. It's one option. You know, discretion of the practitioner I don't think works very well, because we know we miss a lot of delirium if we do that. So I actually just don't know the answer to that question. I would say ideally yes, you know, and even younger than 65 if the patient's high risk. I actually think increasingly that a trained workforce, you know, and judgments being made on these bases is important alongside any sort of rules. So ideally yes, but probably in the real world we should select who we screen, but that might not be a popular opinion.
What do you think, Tanya?
So absolutely, yes, we should be screening everybody over the age of 65. But at the moment, I'd just like to have all my patients over the age of 65 in a cubicle so I could actually assess them for anything. In my department, we use the AMT4 as we ask for that on everybody over the age of 65. And my juniors will tell you that they remember it as the PADI score, place, age, date of birth and year, because they know that if they don't do it, I throw a PADI, and that's their little aid memoir. It doesn't always work, so we do try, and we also have on our electronic patient record that comes up automatically, and if it's done, and somebody scores less than 4, the team should know they need to do some more. But if they score less than 4 on an AMT4, that automatically opens the 4AT to get some scoring. So that is what I'm aiming for. It does rely on people selecting the frailty pathway to get that to come up. We are pushing more and more to get it. My personal feeling is that if I ruled the world and my magic wand was working, an AMT4 would be part of everybody's basic observations. So you would do a pulse, a blood pressure, and you would see whether their level of cognitive impairment had, as a very fast screening tool, whether it had changed. And we see this repeatedly in ED with people who have been lying on the floor for 12 hours, presenting with a very low AMT forward to the ambulance crew. They warm up, they get more comfortable, they improve. We then put them on a trolley for 32 hours and it gets worse again. But you can plot the changes in AMT4, and I think that's where we should start, leading very neatly into a 4AT.
Any other thoughts on that from the panel?
Can I just say something, Josie, on that? And I take Alasdair's point, actually, yeah, screening everybody would be lovely, but actually I wonder if there's a group of people that we need to slightly change our thinking and culture completely. So somebody, let's say, with quite significant dementia, if they come into A&E, and I appreciate this may not always be the case across the country, hopefully they come to A&E for good reason, it's been an acute change. Therefore, the alarm bell should be should be ringing. And actually, I think there's a group of people like to think that we sort of, we presume they've got delirium until proven otherwise in that respect, but actually we reverse the thinking in that respect, that we then perhaps screen them to show that they haven't got delirium rather than showing that they have got delirium. And obviously that way we miss a lot less delirium, and also people get appropriate care, in the right place and time in that respect. But I do think sometimes, particularly at high risk groups, we should be presuming they've got delirium. I appreciate not everybody comes to A&E with urgent need, like my A&E department's just there, just left it, sort of thing. That's often the case, sad. But on the whole, there's a group of people who really, having a dementia, for example, is such a significant risk factor that if there's been, enough reason to come to A&E, let's prove that they haven't got delirium before we actually try to, in our thinking, rather than prove that they've got it. If that makes sense.
Interesting. I guess challenge will be how to actually practically implement that in the real world, isn't it? Different departments may do it in different ways. Just want to try and move on to different questions because we have quite a few interesting questions to get through. So given that delirium is a so-called organic syndrome, whose role do we think it is to manage it? And I was actually going to ask that question of you, Ross.
Well, you know, as I get older, I just rely on various stock phrases for all my opinions, to be honest. And one of them is always that we're always stronger as an MDT. We're always strong as an MDT. So it's, you know, it's, I worry that psychiatrists sometimes run away from that. Oh, it's organic. Yeah, okay. It's whether the patient needs help, and it's whether there's something to add as part of the MDT in that respect. So I do think, you know, like many things, it's everyone's business in that respect. So it's not a case of who's best. It's hopefully like joint working. And even if the psychiatrist liaison service involvement is more about teaching, it's more about the recognition of the difference between hyperalert delirium and depression, which is often more of a ward referral. You know, within the ED, about appropriate use of medication, which is obviously something we need to talk about. But yeah, so on the whole, we're always strong as an MDT. We're always strong as a group, and certainly a group approach of this. And involvement is really important. So it's not just one person. Certainly in the ED, what we'd like to see more of is, I think, one of the most undervalued skills in the whole of the NHS is mental health nursing, actual mental health nursing skills. And we've got a sort of streaming area which are now available to us within the ED. We have mental health assistant practitioners sort of thing, and care assistants who are involved in that, and therefore sometimes it would be appropriate to use them.
Absolutely. 100% agree with you about the value of psychiatric nursing. Such a valuable, we could do so much better if we had more psychiatric nurses in more departments in the hospital, I think. I'm just wondering, Rachel, if you had any thoughts on this, and perhaps a bit more specifically, how do you think old age liaison psychiatrists and nurses, OTs, clinicians can support management of delirium in the emergency department?
Yeah, so I would agree. I think it is everybody's business, and it is a condition that affects all patients, doesn't it? And obviously, you know, more so in the older patient group. I like to think of it and try to pass on to ED colleagues to think of it like a medical emergency, just as the, you know, heart attack is for the heart, delirium is for the brain, and it needs to have that sort of urgent response as we would for patients in resus or trauma patients, you know, because of the, you know, the high rates of mortality and morbidity associated with it. Nursing care is obviously crucial, and I think we really need to be looking at the nursing assistants as well and upskilling those roles, because they're the people that will often be asked to support the patient with nutrition, feeding them, support them going to the toilet and making sure that they're not in retention of bladder scans and that sort of thing. And they're often the person that has more time to spend with the patient and can pick up the subtleties of changes in behaviour. And it's good to see on the News 2 score that there is now a question about an acute change in behaviour to help identify delirium as well. So absolutely, it does need to be an MDT approach. And as we've heard from Professor Alasdair as well, for frail patients, the mind, the body, the psychological, the spiritual, all these aspects that make up a comprehensive geriatric assessment are so important, and that's why we need an MDT to support these patients.
Thank you. Thanks so much, Rachel. Just over to Annabel, Krishnan, Liz in particular wants to ask you this question. This is about, what are the levers that do you think clinicians can use to improve delirium care in their trusts? I think you all have experience of this.
Okay, I'll start with, I think there was a question which, you know, nicely indicates that from Michael. It was a thing about perhaps lightly off the topic. What are your views of absence of clinical responsibility of managing delirium in the community? And then it's talking about like whether we shy away from the responsibility, delirium as an exclude delirium before we take over. So clearly, I think the key point for us to emphasize is delirium is everybody's business. The only problem there is because everybody thinks it's everybody's business, nobody is actually taking ownership. I think that's where the catch comes. So we think it's everybody's business. Oh, is it the OT? Is it the physio? Is it the dietitian? Is it the janitor? So we all think somebody will do something about it, and then sometimes we get the psychs out. That's another thing. And there was another question where they've got issues with medics asking that there is no biochemical change, so we have ruled out the cause for delirium. So people forgetting environmental change, moving patients 3 times within the building. So it is about having that holistic approach and embedding delirium in every hospital. I think Alasdair mentioned about ED. We need to get that our allies, and other common myth is they will say follow the delirium pathway when actually they don't even have a pathway. So everybody says, they write in the notes, follow the delirium pathway. And then if you ask anyone, what's your trust pathway, they may not even have one. So finding out who are the kind of influences. And I remember very vividly in 2013, one of my SPRs, who is now another delirium superhero, she went around every ward, bribing them goodies, giving them awareness. So I give 3 things if at all you want to get delirium in driving: awareness, knowledge, and skill. You need to raise the awareness. Once they are aware, they will get the knowledge, they will seek the knowledge, and then getting the skill will be easy. So finding that right people within the hospital, influencing them, keeping at it is important. Thank you.
Thank you. Annabel, Liz, do you have anything to add to that from your experience?
Liz?
I think you have to create the narrative around why the care is needed, but you also need data. And if you can give data and a narrative, then you have the power in your institution. So most places that are moving to electronic records, it takes a bit of digging around, but you can get your acute trusts delirium coding, and that's really pleasing data to get hold of, because once you start doing some very simple things like writing delirium in the notes, or every time you see someone delirium, say to the admitting team, please code delirium on discharge summary, you start to see the delirium detection numbers coming up in the trust data, and that's a good lever. And also some of the things that we don't like and we find a bit painful to fill in can be really helpful. So things like datics and incidents reports. If you can start linking a series of bad outcomes and events to delirium in the mind of the upper echelons of the acute trust management, that can be a really powerful lever as well. So you very much need the bottom-up approach that Krish has said, but I think the top-down approach is also very useful. And if you can have those 2 together and they meet in the middle, that's when you can really start to get the leverage for change.
Thanks, Liz. Yeah, I totally agree with that from my own experience. Using datics as well can be very powerful. Annabel, do you have anything to add to that?
Yeah, I would say that we're talking about top down, and I've been at a number of meetings over the last few weeks at a national level about sort of flow through hospitals. That's the conversation at the moment. It's all about exit block and flow, and how do we get people in and out quickly. And I think that is one of the things that trusts are going to be having a lot of pressure on them about at the moment. And so that really is where I think we can think about exerting influence. So how would improved delirium care support patient journeys through the hospital from before they arrive, through the ED and beyond? And then how can we look at how we can improve care for our patient group using some of those drivers? So I think we can, some of these big meetings we go to nationally, we find ourselves, feeling like it's very small fish, but we can use those levers for the good of our patient groups.
Thank you. And I can see that time is marching on and still loads of questions to get through. So I'm going to use chair's privilege and just pick the ones that I think are the most relevant. And I really wanted to get to, what are your thoughts on the new RCEM guidance about acute behavioural disturbance? So Alasdair had mentioned in his talk, Rachel, you gave some really good points in an email discussion we were having before. I wonder if you could perhaps talk to that briefly, and then we could all have discussion about that.
Yes, so I made contact with the author of the guidance, and obviously the RCEM is very aware of discussions that have been going on, and I think they have then been in discussion with various colleges as well. What I've been told is that it was never a document that was intended to address delirium, particularly in the older patients. It's more addressing acute behavioural change, often associated with substance misuse, particularly in younger patients, or perhaps those in custody and that sort of condition. It's not relating really to delirium in the older age population group, and I believe the amended version will have that written in the section for older patients, and that's why that section is so small, because it's not intended to discuss delirium and all the non-pharmacological measures that we all know are most appropriate for patients, and all the fantastic strategies that we are all aware of.
Yeah, I think you've got your hand up. Did you want to come in on that?
Yeah, I think that's just, it's one of those classic examples of ED is a very strange place when you compare it to all the other specialties. And even with my frailty head on, when I read that guidance, my automatic thought was, this is the man that's holding down 10 police, that's being held down by 10 policemen, and he's 22 and he's built like this. And that's me with my frailty obsession head on. So it was very much aimed at ED ED staff, who I think the majority wouldn't have even considered this as delirium management. The flip side is that I utterly agree with everything or the other thing I want to say is that I agree with what everybody's saying about flow and all the rest of it, and things that we can do better to help our patients with delirium. We just need to be very, very realistic about what the state of the country's EDs are. I fully agree that we need data access, of which I will be on the receiving end of a lot of them. And I just want to share that we had a situation where a patient with delirium left our department, crossed the road, got on a train and ended up at the other end of the country. And this was quite rightly day-text, but when you're doing the investigation and trying to action something as a result of that, you have two very, very different lists. You have my wish list of how I would like this patient to be managed, which is with an ED lead for the brain failure, which is probably caused by multi-organ failure and is an absolute 100% medical emergency, and you need me there, moving very swiftly into a multidisciplinary approach with the patient very, very swiftly leaving the ED into a dementia-friendly area and not moving again. And then on the other side, we have what we can do in ED. And that is, I've got my patients there for 40 hours being moved so that I can get my category 1 resus call in. And we've thought very carefully about how we can deal with this. And I hate the fact that my patients with delirium don't get the care I want to give them. And I think any ED consultant will say that about the majority of their patients, whatever they come in with at the moment. But just be very careful. If you're going back to your hospitals, we want all the help we can get. But when you're pushing at these meetings, be realistic that as well as trying to move people with delirium into the appropriate area, we're also trying to move that patient with the MI, the respiratory arrest, all the rest of it. And if you haven't taken a walk through your ED recently, go down and spend an hour following someone. Because if you did ED 2 years ago, it is a totally different ballgame there. And I think the one thing people should take away, in fact, 12 months, totally different. If you want to help ED in any way, just go and see what the real thing is down there. And this is obviously a liaison service, and you're all so interested and we could do such great work, but it needs to be hugely realistic. I'll get off my hobby horse now.
Thank you. I think that's very, very important comments, Tanya. And absolutely, we need to live in the real world and see what is actually going on in the departments that we are asking people, if we're asking people to do things and implement changes, we need to understand the pressures that they're under 100%. And I think liaison presence in A&E ED is really, really important. I'm very aware that it's 5 o'clock now. We could carry on talking about this for a very long time. I'm very happy to continue the discussion if panelists are able to stay a little bit longer, but equally fully understand if any of you need to go, then do please say your goodbyes and thank you very much. Are you all happy to stay on for a few minutes?
Yep.
Fantastic.
Yep.
Thank you very, very much. Really appreciate it. Does anybody else have any thoughts about the new RChem guidance? So we've heard from Rachel and Tanya. Ross wants to say something.
Yeah, I mean, it's about the guidance and I appreciate when I read it, it felt very much like guidance more for the younger people as being said. Having said that, it still has droperidol in it, which was removed from rapid tranquilization advice nationally 20 years ago, and you've struggled to get hold of it. It's also got IV chlorpromazine in it, which just frightens me and should frighten every cardiologist in the country as well. So even if you're young and big and psychotic and off your head on steroids, etc., and those really difficult cases to manage, yes, ketamine, groovy, I'd go for that. But actually, there's a few other bits in there that aren't grand. But it does bring on the question about medication. And it is this problem in delirium that I think sometimes national guidance struggles to really differentiate between what's rapid tranquilization and what would be pharmacological treatment try to do for symptoms. And with that comes the issue, particularly because we're talking about older people, about haloperidol. Very few of the studies, virtually no studies, really involved older people, and they certainly don't, many of them include people with dementia. And therefore, the question would be for me as old age psychiatrist, or generally for other people, do you use haloperidol for older people generally for dementia? And if you do, grand, super. But so, and if I don't personally, and therefore if I don't use it for people with dementia, why would I use it for somebody with delirium and dementia? Because actually, this is a syndrome. It's very heterogeneous in that respect. You can look at palliative care patients, the AGAR study, haloperidol, there was higher excess mortality compared to placebo in the haloperidol group. What we do often, particularly in psychiatry, and I'm sure in other specialties, is you tailor the medication to the person's comorbidities, the symptoms they have, their biochemical profile. So I really do challenge the idea that there's only really one antipsychotic recommended. That has to be through NICE because the way they work, that it's licensed. But there's much better side effect profiles. Every time you see, and they've only just added in the guidance, it's always been a problem of, oh, be careful with people who may have Parkinsonism. Oh, be careful with people with QTC. I'll tell you one way to be careful about is don't use it, and use something that actually, if you need rapid tranquilization, doesn't have those problems. Now, nothing is perfect, but we often, as I said, choose antipsychotics on the people's difficulty. I must admit, something that doesn't have much of an evidence base, if at all, for delirium, but I utilize reasonably successfully because of its side effect profile, is aripiprazole. Hey, it's got one of the best side effect profiles out of any antipsychotics. I don't have to worry about a lot of things. Risperidone, which Alasdair mentioned, I think is a reasonable choice as well. In that respect, it gives you that D2 activity antagonism as well. But I don't have to worry so much, obviously, about QTC and about Parkinsonism. Lots of people come into A&E where we don't know all their history. And I've seen too many people who are too agitated to have an ECG, and then when you look back at their notes, they've got a QTC of 550 in the past. Or actually, it turns out that dementia diagnosis or the confusion diagnosis was actually dementia with Lewy bodies, and we've just given them haloperidol, and now they're really in trouble. I think the best way to avoid those problems is not have it, but appreciate that is against national guidance. But I would query the national guidance for older people.
Thank you so much for that, Ross. It's very valid points. Chris, you had your hand up at one point. I don't know if that's something you wanted to.
Yeah, just going back to the RChem, I think it's all about semantics. I think Tanya, you made a very, very clear articulation. The difficulty is calling it an excited delirium. Suddenly, untrained, inexperienced people can do things, damaging things to our older adults. That's the biggest worry. I think people understand somebody, 10 stone, 20 stone, very aggressive patient, totally different ball game, nothing to do with delirium, wanting to tranquilize and, deal with their aggression is very different to a frail older adult having a good going delirium. And as Ross already pointed out, there were things that were slightly out of in touch with, like, with, like talked about droperidol. And we don't want, it's like a double-edged weapon. We don't want somebody inexperienced seeing a guideline and acting on it without having that pragmatism. I think that's where the catch comes. But apart from that, again, when you are giving medication for delirium, this is again to echo Ross's point. If you are giving medication for delirium, this is my strap line currently. There is no treatable medication for delirium. There is no treatment for delirium. So don't call it I'm treating delirium when you are giving haloperidol or any antipsychotic. If you are going to treat the agitation using rapid tranquilization, use the safe and effective way to do it, rather than calling it treating delirium. That's when some of our hypoactive delirium patients unnecessarily get treated with haloperidol. As soon as delirium doesn't equate haloperidol. Again, I agree with Ross. So if it is a treatment of delirium, there is no medication available. I'm sure Alasdair will correct me if that's right.
Alasdair's got his hand up, so I think he's got something to add.
Can I speak now? Yeah. So just to reiterate that we've just made a gigantic mistake, in thinking that delirium is treatable with drugs. It's just a myth. It's a gigantic global cultural mistake. It's like giving colchicine for delirium or antifungal cream for delirium. It doesn't work. There's no drug. There's no drug treatment of delirium. There is drug treatment of psychosis. There's drug treatment of emotional disturbance, which can occur commonly in the context of delirium. But I think that we have to unpick this, and see it as a treatment option within delirium for certain features of delirium. But there's no drug treatment of delirium. And in fact, I've visited American hospitals where people are on 3 antipsychotics just because they've got delirium. I mean, it's sort of an aberration that needs to be fixed. So the ABD thing, I worry that it'll just, anyone is a bit restless and agitated and going, hey, in the ED, they'll just reach for the ketamine. That's my worry, because that's doctors often, especially inexperienced doctors, they love it. They love that simplicity, the arc of agitation drug, and the harder work of looking for all the causes, trying to reassure someone, bring a family member in. The default is often just to reach for the drugs, I'm afraid.
Got Tanya, then Ross, desperate to chip in. Tanya, do you want to go first?
No, I'm sorry, I disagree. I don't think that is the mentality in ED. I think we have a very challenging situation where we occasionally, because of the difficulties with our environment, we will end up sedating people to allow ongoing treatment. I don't know of anybody that thinks delirium can be treated with drugs, and we very much, it's restraint we're talking about to allow the management. And I'm terrified and confused in my department, and I work there every day. So, it's unsurprising we see people, but number one, I really don't think people believe that this is a treatment for delirium. This is very much about keeping people safe. And it came out of several cases where people were so aggressive in the ED, they were sent to police cells and dropped dead. And that's where the guidelines came from. I work with Marianne Gillings. She's one of my fellow consultants and a very impressive farm in her background with toxicology. And yes, we thought we had to go so much further with that guidance to allow us to get people flat enough to treat them rather than being taken away by the police. And that's very different to treating delirium.
I want to clarify, I wasn't saying that that's what I think happens in the ED. In fact, I'm delighted to hear that isn't the belief in the ED. It is the belief in geriatrics wards all over the UK, or in medical wards all over the UK. So it's actually not the ED I was referring to. I'm talking about the general belief that when somebody has delirium, you prescribe an antipsychotic or something.
Yeah.
I totally get where you're coming from, and I think we have to be, if you don't work in the ED, you have to be careful to make assumptions about and the thinking behind it. But I think it's also important to realize that I have seen many junior doctors prescribe 2.5 milligrams of haloperidol for a slightly restless person who just needs to be given a cup of tea and a chat, you know, and that's what I'm concerned about, is that there'll be a percentage of overprescribing if people misinterpret what the aim behind these guidelines was.
And I think that's another point of where those guidelines are meant to be implemented. They should never be implemented on a medical ward, but as a small DGH, we have consultant presence until midnight from 8 a.m. and normally 24 hours a day. And your bigger major trauma centres will definitely have 24-hour consultant cover. And sedation in this way is not done in the same way as it would be on the wards with, you know, the junior SHO who is desperately trying to get this under control and can't find anybody more senior. So it is really important that we keep this guidance within the area that it's meant for. And I agree, it would be very, very dangerous if people picked up this ED guidance, moved it to the ward. It's different in ED.
And Ross, please, you've been waiting patiently to talk.
That's right. No. There's a couple of points coming back to the ED guidance. So the thing is, you know, in psychiatry, we're very good at prescribing antipsychotics. We're even better at not prescribing them as well, which is, you know, a skill in itself, which I kind of guess is Alasdair's point. And I appreciate there's lots of geriatricians also very good at not prescribing antipsychotics. But the ED guidance is more rapid trank, and there's good rapid trank guidance can be used. Ketamine, you know, is a reasonable choice in that, but there's lots of bits that don't quite fit. I think the key thing was the delirium guidance on the wards is, you know, with the HELP study and other parts of advice of NICE, etc. We know the non-pharmacological things that can be helpful, you know, that actually help with that. The question is for us, I think all of us, particularly in the NHS, and particularly things that Tanya raises, that ED being busy but wards being chaotic, is why do we struggle to do these things? Because when you look at those interventions, they're called good care. That's what it comes down to, you know, the avoidance and addressing of constipation, dehydration, make sure people have got hearing aids and glasses, etc. Reorientation, that's good care. And the question, you know, the query is, why do we struggle to do that? Because nobody plans to not do that, if that makes sense. So we need structures, we need bundles of care, but actually a lot of it comes down to the distractions, the staffing levels. You know, there's even been RCTs that have struggled to do their treatment, non-pharmacological treatment section of wings because of, you know, problems with staffing. It's therefore, you know, does it readdress, you know, the environment, staffing levels, and training? When it will come down to, you know, we don't get that bit right all the time before, you know, medications are absolute side issue in some respects. You know, it's not the mainstay. The mainstay is the other aspects of recognizing delirium, that, you know, the prevention work and management work, and making sure that's implemented. And, you know, I see that happen lots of times where it does work, and actually lots of times where, again, usually due to the you know, sometimes lack of structure, but as I said, staffing levels, chaos, the other distractions going on, the busyness of everywhere, and that's something we have to address. I'm going to finish just saying one thing we haven't talked about is another way to help manage delirium in the ED, which is, you know, the main topic, is to manage it in the community. And that's something that we need to all get better at. And that there is a role for mental health, because again, I think an MDT approach of that, of actually trying to manage people in the community with delirium, try to keep them probably in the best place available for them, is something we also haven't, you know, we need to address and develop.
Absolutely, and we could do a whole other session, probably a whole day, about managing delirium in the community, couldn't we? I'm going to start wrapping things up, but Annabel's got her hand up. So do you just want to make a final point on that, Annabel?
Sure, I'll be really brief. I was just thinking as people were talking about the impact of discontinuity of care on delirium management. One of the things that I always teach doctors in training about delirium is, if you give a drug today, it will have an impact tomorrow. So if you get somebody sleeping this afternoon, they will be awake tonight. They will still be groggy tomorrow. That actually, if you don't see the impact for 24, 48 hours of the drug that you give, then you may think that you've done something good because it's managed things in the moment. And so I really urge people to sort of follow that patient, see what happens to them and the impact of those drugs over the coming days, and it is days. And I think as liaison psychiatrists, we often have the benefit of being able to see patients over days, when often our acute colleagues don't, because they rotate so quickly through patients or through departments. So I find that really helpful as a teaching point that people can take away and reflect on.
Thank you. Okay, so now I'm going to wrap up by, I was going to ask you for your 3 wishes for delirium care, but I'm going to ask you for 1 wish to improve delirium care in the emergency department. Sorry, Liz, I haven't heard from you in a while, so I'm going to pick on you first.
I feel really strongly about the side-by-side model of liaison psychiatry. So I actually work in ED every Friday morning alongside, and I love it, and it's helped so much. And I think walk in my shoes and you really begin to understand both ways things are going. So I would recommend, even if you're a bit nervous and about throwing yourself into the emergency department, just take the plunge, because I've learned so much and I've got to know my ED colleagues, and that just benefits patient care massively.
Thank you, Liz. And Alasdair, how about you?
My 1 wish?
1 wish.
Learn how to look someone with delirium in the eye, find out if they're distressed, and be kind to them.
Oh, I love that one. Rachel, how about you?
That's the hard one to follow, isn't it? So we've said about identification and support for family members, but I think for me it would be a delirium pathway spanning the community, acute and whatever voluntary sectors. We're seeing a lot of patients coming into the to the hospital because of COVID and lockdown with delirium that don't necessarily need to be in the emergency department. And as Tanya said, they're stuck in ambulances for hours and hours, then they're in corridors, then they're moved several times, and it just is the perfect storm to make the delirium worse, or if they didn't come into hospital for causing delirium. So really better community care for delirium and an exit route as well that doesn't mean staying in hospital for months and months. That's quite long, sorry.
Yeah, a clear pathway. And Tanya, how about you?
Very simply, I would have flow. So flow out of my department into the hospital, but more importantly into the community. Allow the patients that have finished their ED or shouldn't be in the ED to not be there, and then I can ensure my ED clinicians do a better and the right job for those patients. No other department would work with 3 patients in every single bed and still be asked to operate. So give me flow, and everybody's care will be the way we want it to be.
Fantastic, yeah, sort out the front door.
Back door.
The back door. So the front door and the back door, I guess. The whole thing. Ross, what would your wish be?
I'm going to choose a very minor thing, to be honest, because everybody's chosen broad things. I'm going to choose something minor thing, which we haven't really talked about, but it's to do with delirium is multifactorial, lots of different pathways. But obviously, one of the things that's talked about is the cholinergic system. Understandably, not all delirium affects that system. And that is, can we all agree to use for our anticholinergic burden the check at www.medicheck.com? There are too many other scales out there which are incorrect, to be honest. I trust the people from the Maudsley. I bless the Royal College of Medicine have got a teaching webinar thing, a program on delirium, and in their anticholinergic drugs they have listed lorazepam. It isn't. Theophylline. It isn't. That's not the Royal College's fault. That's just come from another source. Darafenacin is always the check. Darafenacin is specific actually, so whilst it's anticholinergic, it doesn't actually affect your brain. So I'm a big fan of trying to reduce that burden. We're in the brain saving business. Let's save people's brains before they even come to A&E by trying to at least reduce their anticholinergic burden. But let's all please use medicheck.com. That's without a K. Medicheck without a K.com, and then we'll make good drug choices and say goodbye to amitriptyline for older people forever.
Love it. Yes, that's one of my biggest things that I do, is try to get rid of amitriptyline in older people, whoever comes in. Really, really important. Annabel, your 1 wish.
So I think I'm going to think about a system-wide one. So involving liaison psychiatry in any system-wide decision-making about delirium care, and particularly thinking about using the wisdom of our liaison nursing colleagues who are brilliant at delirium management. And whenever our liaison nurses have been involved in the care of patients with delirium, they have always added great value to the care. So this is a big shout out to liaison nursing.
Fantastic. And Chris, you've rejoined us. I think you had to go to escape the building before it got locked, but maybe you've rejoined on your phone. If you're there, could you tell us your 1 wish for improving delirium care in ED.
Can you hear me?
Yes, we can. Yes.
Yeah, my one wish in delirium care is everybody has that business. Everybody knows that delirium has to be detected and risk is reduced. And I will have a second wish because Ross has mentioned polypharmacy is something, it's a nightmare for older adults. If there is a medication review and polypharmacy, deprescribing is something has to be done by every qualified clinician. Deprescribing may be the first wish.
Brilliant. So that's all of us apart from me. Do I get a wish as well? Hopefully, yes.
Yeah.
My wish would be obviously all of yours because they're excellent wishes, but I would also wish that we give really careful explanation to people and their families and carers as to what is going on and give them information to go away with because they may not absorb it all at the time, particularly carers. I think it's incredibly scary experience to see your relatives going through a delirium, and we can harness the power of the family. I think Krish has used that phrase as well to support people, and they can't support if they don't understand. They may just be frightened. So that would be my wish. Good and careful explanation to people and their carers. So we have gone massively over, and I think we could carry on talking for ages. It's a learning point for us that when we do this again, we need to schedule longer sessions. We've still got 62 people on the call, which is fantastic. You obviously all stayed on to hear this discussion, and we really appreciate it. There may have been some problems with the feedback form link I've seen in the chat. I'm going to very briefly just share a slide with the QR code, which you may be able to see. I hope you can see now. You guys see that? Yeah, so if that link hasn't worked for whatever reason, have a go with the QR code. We will wrap up the session now. We'll be in touch very soon with a follow-up email following this session. We'll include some links and resources that have been mentioned throughout this talk, and we'll keep in touch with you about future events. And once again, massive thank you to Professor MacLullich, to Alasdair, and to the rest of our wonderful panel, and to all of you for joining us today. Thank you very much. Have a lovely evening.
Thank you.
Bye.
And thanks for great chairing, Josie.
My
Like
pleasure.
a pro.
Well done,
Thank you.
Yes, definitely.
Great event. Thank you very much.
Bye.
Thank you. Thanks,
Bye.
Alasdair.
Good to see you all. Bye.